Hi everyone, and welcome to the CAQH webinar presenting the 2019 CAQH Index findings. My name is Maggie New, and I am the Communications Assistant for CAQH, and I will be running the technical side of today's webinar. Before we get started, I'd like to review some housekeeping details for all those listening today. Today's session is being recorded, and by early next week, you will receive a link via email to the on-demand webinar that you may share with others. The recorded webinar will also be posted on our website. Your phones will be muted throughout the webinar today. All questions should be submitted online. You may ask your question at any time throughout the session. Simply type your question into the right side of the GoToWebinar panel. We will address your questions at the end of today's presentation. Now I'd like to introduce today's presenters. They are Kristine Burnaska, Director of Research and Measurement for CAQH Explorations, and April Todd, Senior Vice President of CAQH Core and CAQH Explorations. And I will turn it over to April.
Great, thanks Maggie. Good afternoon. Welcome everyone to the 2019 CAQH Index webinar. If you happen to hear a few sirens behind us, it is part of the ambiance of working in the DC metro area. So apologize for that in advance. You'll probably hear some of those sirens throughout the call. So for the agenda today, we're going to do a brief overview of the index and how it is conducted and who participates, as well as a high-level overview of the findings. And Kristine will walk through some of the detailed findings for each of the transactions that are measured in the index as well. So first, for the CAQH overview of what is the index and how is this conducted. So the CAQH Index, this is a national benchmarking survey. It is a survey that tracks the adoption of administrative transactions, and in particular tracks the cost and the time associated with those transactions and estimates the savings opportunity that can come from making those transactions more automated and transmitted in an electronic way. This is the 7th annual report that CAQH has done of the index, and so we have been able to track industry progress over time towards the movement from manual to electronic transactions. Of particular interest this year, we have some new measurement that you will see reported throughout the index. In particular, we have benefited from increased provider participation this year. And from that increased participation, we are able to have enough sample to provide more detailed information on partially electronic transactions or transactions transmitted through web portals and IVR systems. A new addition we've also made this year to the index is to report information on the spending throughout the different transactions that are tracked. In addition to the costs that have been avoided by the industry to date by moving from manual to electronic transactions. And then lastly, we continue to report on the savings opportunity that exists from continuing that movement from manually and partially electronic transactions to electronic transactions. So the index benefits from having a great advisory council. This advisory council exists to provide support and expertise in the data collection and reporting of information from the index. Experts in administrative transactions from across the industry participate on this council, and this represents health plans, providers, vendors, government, and other industry partners that provide this expertise. This year in particular, want to thank the Advisory Council for all of their stellar work in advising the data collection and participation in the index, and in particular, just some outstanding efforts from the Council this year to really drive some increased participation across the industry and in particular among providers. So next, just want to provide a high-level overview of which transactions the index tracks. So the index asks information about each administrative transaction along the workflow both before and after a patient has an encounter with a provider. So our transaction measurement starts with transactions associated with when a patient encounter is scheduled. And so these transactions include eligibility and benefit verification, also information around prior authorization, and provider referrals that can occur when a patient encounter occurs. It also includes transactions around when a provider submits a claim, includes all of the information that is submitted on that claim, any medical documentation included as an attachment related to that claim, as well as any need for coordination of benefits where multiple payers may be responsible for paying for the care of that patient encounter. It also includes transactions related to the adjudication of claims. And in this instance, we track claim status inquiries that providers send to help understand where in the process a claim is in being adjudicated and paid. And then lastly, we also track transactions related to provider payment from the health plan. And this includes the claim payment itself, as well as remittance advice that explains how a claim was paid and why a claim was or was not paid to a provider. Next, before we go through some of the detailed results associated with the different transactions, I want to go through a few definitions for clarity and help in understanding some of the results. So first off, want to describe what we mean by transaction costs. So costs and the savings estimates that you see in the index account for the labor, time, required to conduct the transaction. These costs do not include systems costs, and they do not include costs outside of the transaction itself that may be associated with any pre-work or follow-up work. So for consistency over time and to track the efficiency of the transaction itself, we are just tracking the labor, effort, and time associated with transmitting the actual transaction. So in terms of the transactions that we are measuring, we define a transaction being conducted in one of three modes. So there is an electronic transaction. That is an automated transaction that's conducted using the standard adopted under HIPAA. In some instances, there's not yet a HIPAA standard, but we have used the most commonly used electronic standards in the industry for that electronic definition. In particular, this applies to attachments. The second way we classify a transaction is a manual transaction. This is a transaction that requires end-to-end human intervention and interaction. This includes things like telephone calls, faxing, mailing, and or emailing information. And then lastly, a third mode that is tracked is a partially electronic transaction. This is a transaction that may have some manual components to it, but also has various electronic components to it that help to automate the process. And so what is typically included in a partially electronic transaction are things such as web portals and interactive voice response, IVR phone systems. So some other definitions that are helpful to have as background before we review the details are the financial metrics that are included in the index. The first definition is potential savings. What we mean by potential savings are the savings that are associated or could be associated from switching from manual and partially electronic transactions to fully electronic transactions. This is a metric that has been included in the index since the very first report that was done. This year, we have added 3 additional financial metrics to help provide more context for understanding the savings that can still occur for the industry and the savings that the industry has already achieved from the movement from manual to electronic transactions. So the first metric is estimated spend. Estimated spend is essentially the amount that the industry currently spends on transactions. This is a combination of the share of volume that is transacted electronically, manually, and partially electronically, times the cost of transmitting those transactions. Within the estimated spend, there is a component that is the electronic spend. This is the share of the cost of the spending that is associated with those transactions that are purely electronic. You'll see that the estimated spend is a combination of the electronic spend and the potential savings. The last financial metric that is new this year is a metric called cost avoided. Cost avoided represents the amount that the industry has saved on an annual basis from the movement from manual and partially electronic transactions to electronic transactions. How this metric is calculated is it assumes that if all transactions were conducted manually, what the cost would be, and subtracts out the amount that it would cost for electronic and the amount that could continue to be saved that is currently being spent. So those are some definitions so to review before we get into some of the details. In terms of the reporting of transactions, every year we ask about roughly 13 different transactions. These transactions can change from year to year depending on trends and transitions in the industry. This year, most of the transactions that we asked about were similar to prior years, except for a couple. We have started to ask information around the transmission of information for value-based payments. So we've started to ask about VBP attachments or medical documentation. We've started to ask about that. We do not yet have enough volume to be able to report it, but we anticipate being able to report that in future years. We've also made a change this past year in generally how we ask about attachments. If you may remember, there was not enough volume reported to report on attachments last year. This year, to help with that reporting, we have combined our request for information on attachments to include those representing prior authorization claims and appeals. So those are all together in one area. So this year, for the medical industry, there are 8 transactions reported for medical and 5 transactions reported for dental. So the 2019 data collection effort is very similar to previous years. The time frame was conducted from during the summer through the early part of the fall. Similar to prior years, the results reported in the index represent roughly half of medical covered lives and roughly half of dental covered lives. As I mentioned previously, through the help of our advisory council, our provider response more than doubled this year, and so again want to thank those organizations and individuals that helped improve that response. And then we had a number of enhancements that were done throughout the year, in addition to the recruiting to bring in participants. As I mentioned before, we've had some change in how we've asked some of the questions, and also some of the new analyses that we're able to report this year are a result of some additional questions, as well as more response from providers related to partially electronic transactions and the new financial metrics that I just reviewed. So with that, we'll go over some high-level findings. At a very high level, what we've noticed this year in the index is that electronic adoption continues to improve across the medical and dental industries. For dental adoption, we saw an increase in every single transaction this year. So the dental industry is definitely making improvements in this space, although they do still significantly lower than the medical industry. They're making significant improvements in electronic adoption. Secondly, overall industry transaction volume continued to increase. For some transactions, much more than others, and we'll review why that is the case later today on the call. From a cost savings perspective, the industry cost savings opportunity increased slightly from last year and represents 1/3 of the spending on administrative transactions. For the medical industry, the savings opportunity remained roughly the same as last year, with the bulk of the increase in the cost savings opportunity coming from the dental industry. Fourth, another high-level finding from our ability to track in more detail information on partially electronic transactions such as web portals is that we have quantified the savings opportunity associated with those transactions that have a sizable amount of the volume that is going through web portals. And then lastly, one key finding that is new for this year's report is that we have identified some significant annual costs avoided by the industry, so significant achievement that has been made by the industry to transition from manually and partially electronic transactions to fully electronic transactions under the HIPAA standard. So with that, I'm going to hand it over to Kristine, and she'll walk through some of the more detailed results from the report.
Thanks, April, and thank you to everyone attending the webinar. I'm now going to share some high-level findings with you related to adoption, volume, and savings opportunities. Looking at medical plan adoption, you will see that electronic adoption remained relatively stable or increased for the 8 transactions reported. The biggest increase occurred for claim payment, followed by coordination of benefits. Moving to the dental industry, for the first time since 2015, adoption increased for all 5 dental transactions. Eligibility and benefit verification and remittance advice adoption increased the most at 5 percentage points each. Slide 15 highlights the relationship between volume and potential savings opportunities for the medical and dental industries. Medical volume increased 17% from last year, while dental volume increased 3%. The potential savings opportunity also increased for both industries. Looking at the overall industry savings opportunity, you see that the savings opportunity increased 7% this year from $12.4 billion to $13.3 billion. The increase was mainly driven by an increase in this dental savings opportunity from $2.6 billion to $3.4 billion. We are now going to focus on the average cost per transaction. Looking at the table on slide 17, you will see that the biggest savings opportunity for the medical industry is for prior authorization, followed by claim status inquiry and eligibility and benefit verification. For each of these transactions, manual costs are high for providers and plans. Looking across all the transactions, each manual transaction on average costs $5 more to conduct than an electronic transaction. If all 8 transactions were conducted electronically, the medical industry could save as much as $42 per patient encounter, with the majority of savings being for providers. Savings also exist by moving from partially electronic portals to fully electronic transactions. The largest savings opportunity is for prior authorization. $2.11 can be saved on each prior authorization by conducting the transaction using the mandated standard as opposed to a portal. Switching to the dental industry, the biggest savings opportunity is for claim status inquiry, followed by eligibility and benefit verification. Similar to the medical industry, manual costs to conduct these transactions is high for both plans and providers. Looking across all 5 transactions, on average, manual transactions cost almost $6 more to complete than an electronic transaction. If all the transactions were conducted electronically, the dental industry could save $30 per patient encounter. The savings is 3 times greater for providers than for plans. Savings opportunities also exist by switching from partially electronic portals to fully electronic portals, with the biggest savings being for eligibility and benefit verification. This year, we were able to not only report on potential savings opportunities, but also on the overall spend associated with conducting administrative transactions and the cost avoided through automation. Looking at the medical and dental industries, you will see that they have spent about $41 billion conducting administrative transactions measured in the index. Of that, 13.3 billion, or 33% of the spend, can be saved by switching from manual and partially electronic transactions to fully electronic transactions. The progress the industry has made to automate the administrative transactions has saved the industry over $102 billion annually. Focusing on the individual medical transactions, the medical industry has spent about $34 billion conducting these 8 transactions. The highest spend is associated with conducting eligibility and benefit verifications, followed by remittance advice and claim status inquiry. These 3 transactions represent 80% of the total annual spend. Despite the high spend associated with conducting eligibility and benefit verifications, the medical industry has avoided over $68 billion annually by automating this transaction. By automating claim submission, the industry has avoided almost $11 billion in total annual costs. Switching to the dental industry spends almost $7 billion conducting the 5 transactions listed on the slide. Spending is highest for eligibility and benefit verifications, followed by claim payment and remittance advice. These transactions account for almost 75% of the total annual spend. Through automation, the dental industry has avoided almost $3 billion in annual costs associated with conducting eligibility and verification checks. In addition to estimating cost savings opportunities, we're also able to estimate time savings opportunities associated with switching from manual to electronic transactions. On average, providers spend 7 minutes more conducting a manual transaction as opposed to an electronic transaction. For patients requiring all 7 transactions, a provider could save 50 minutes by conducting all the transactions electronically instead of manually. The transaction with the highest time savings opportunity is prior authorization. On average, a manual prior authorization required 21 minutes to conduct, while an electronic transaction required 4 minutes to conduct. This year, we were also able to estimate the time a provider can save by switching from partially electronic to fully electronic transactions. A medical provider could save, on average, 9 minutes by conducting transactions electronically as opposed to via a portal. Focusing on the dental industry, we found that on average, it took providers 8 more minutes to conduct a transaction manually compared to electronically. For a patient requiring all 5 dental transactions studied, a dental provider could save on average 38 minutes by switching from manual to electronic transactions. The transaction with the highest time savings opportunity is claim status inquiry, followed by eligibility and benefit verification and remittance advice. Dental providers reported that they spent 17 minutes on average conducting a claim status inquiry manually compared to 4 minutes electronically. Looking at time saved by switching from portal to electronic transaction, we found that on average, dental providers could save 3 minutes by conducting transactions electronically, as opposed to via a portal. We are now going to dig deeper into the individual transactions, starting with eligibility and benefit verification. For each transaction, I will share trends in adoption and volume, and where possible, provide context for the findings. On slide 26, we see that adoption of eligibility and benefit verification dropped slightly for medical plans and rose 5 percentage points for dental plans. For both industries, manual use has dropped. The volume of eligibility and benefit verifications increased for the medical and dental industry and remains a transaction with the highest volume for both industries. Plans and providers reported that the increase in volume is due in part to the increase in plan complexity, which may result in more manual transactions. Dental plans and providers have indicated that manual intervention is often needed when dealing with the unique dental needs and requirements. Moving on to prior authorization, we see that adoption remains low despite the fact that a standard is in place. Barriers such as lack of vendor support, state laws mandating manual interventions, and inconsistent use of data content have been cited for lack of adoption. This year, we saw an increase in portal use, which aligns with effort by plans to encourage providers to submit prior authorization requests through plan-specific portals. The volume for prior authorizations remains one of the lowest among the transactions studied. And despite plans requiring fewer prior authorizations this past year for services, providers still find this transaction a challenging, as cited in a recent MGMA study. In the future, we expect to see the volume of prior authorization requests increase as medical plans indicated that new innovation in certain service categories will result in the need for more prior authorizations. Focusing on claim submission adoption, we see that this transaction continues to have the highest adoption rate for medical and dental plans and has remained relatively stable for the last 3 years. Despite the stable adoption rates, volume has increased for both the medical and dental industries. This increase in volume closely mirrors the increase in volume for claim payments. Claim submission, however, is higher than claim payment volume, given payments are often made in bulk, where one payment is associated with multiple claims. This year, we are able to report on attachments, which includes prior authorization and claim and appeals attachments. In the 2017 report, attachments only included claim attachment. It is important to remember this as you look across the years, given the measures are slightly different. Adoptions for attachments is the second lowest among the transaction. The lack of an attachment standard has deterred vendor, plans, and providers from investing in solutions to help automate the transaction, resulting in high manual burden. Looking at the volume of attachments exchanged on slide 36, it is worth noting that the volume remains among the lowest and accounts for less than 1% of total transaction volume. Moving on to coordination of benefits, we have seen a steady increase in adoption. This transaction has the second highest adoption rate after claim submission. Partially electronic use has dropped to an almost non-existent level. The growing use of electronic COBs may be a result of the industry working together to share plan enrollment data electronically to help with the coordination of patient benefits. On slide 40, we see that the adoption of fully electronic claim status inquiries dropped slightly for medical plans and increased for dental plans. For both industries, manual use declined. Looking at the volume of claim status inquiries, we see a drop in overall medical volume driven by a decrease in electronic and partially electronic volume. The decrease in medical volume may be due to the fact that providers are only checking on the status of a claim every 30 days. This may be the result of quicker adjudications and payments from plans. The increase in manual volume for both industries may be due to the lack of acknowledgments, resulting in providers calling plans to find out the status of a claim. This results in high manual costs and time to conduct. For medical plans, claim payments saw the largest increase in adoption. This corresponds to the increase in EFTs reported by NACHA. Dental adoption remains low, due in part to the lack of trust in electronic exchange mechanisms. Looking at the volume associated with claim payments, we see that the medical industry experienced an increase in volume driven by an increase in electronic volume. Electronic and manual volume increased slightly for the dental industry. As mentioned earlier, the increase in volume closely matches that of claim submissions. And finally, we will discuss remittance advice. On slide 46, we see that adoption increased for both the medical and dental industries. While dental adoption is up, we still see high manual use. We have heard from dental providers that the lack of information on a remittance advice results in dental providers printing EOBs and manually reconciling payments. For both industries, remittance advice volume continues to increase. The medical and dental industries saw an increase in both electronic and partially electronic transactions and a decrease in manual transactions. The increase in electronic and portal transactions is due to duplicative postings, which allows providers various opportunities to access the information. That concludes my discussion of the detailed findings. If you have any questions, please ask them at the end of the presentation. With that, I'm now going to turn the presentation back over to April to discuss actions for the industries to consider to help maintain and improve upon the achievements just discussed.
Thank you, Kristine. So in the call to action, there are a number of efforts that we highlight in the report for the industry to take. The first that we highlight is the need to focus efforts to reduce provider burden. As we highlight in the report, much of the savings opportunities can exist for providers. And so focusing on those items that can help reduce provider burden would significantly reduce administrative costs in the industry. And those are transactions such as eligibility and benefit verification, claim status inquiry, and prior authorization. Second call to action for the industry is to not look at the achievements made to date and sit on our hands, but to think about what is coming down the pike and the evolving changes that are being made in the industry that we are seeing and hearing from both plans and providers that are not easily addressed through the way that existing standards and operating rules are structured. And so there is a need for those standards and operating rules to adapt and to adjust to changing market needs. And in particular, a need for all stakeholders to come together to align on those business needs and work towards future-looking solutions. Third, as we look for solutions to both address current industry problems as well as anticipate those of the future, there is a need for vendors to more quickly adopt all standards and operating rules, in particular for the dental industry, where there is a severe need for automated solutions for a number of those transactions. And then lastly, a call to action that we continue to work on in explorations is continuing to expand the research related to the administrative workflow. There are some enhancements that we've been able to make to the survey this year. We continue to look for opportunities to ask about emerging market trends, to continue to start to ask those questions, to start pulling in volume related to some of the newer transactions and newer needs for the industry related to value-based payment, for example. So with all of these actions for the industry to focus on, we ask the industry to take a look at those and are open to any comments and questions as well. And I'll hand it back over to Maggie to open up the line for any questions.
Great, thanks, April. So yes, like April said, now is the time during the webinar where we answer questions from listeners. Please submit your questions via text by entering them in the questions section of the panel on the right-hand side of your screen. So I can go ahead and actually address one of the first questions we got, which is, will the presentation be available after the call? Yes, the slides and a recording of the webinar will both be available via email. We'll send it out to all of the registrants of this webinar. It will be available and posted on the CAQH website within a week of the webinar. So be sure to look out for that.
And so we'll start off with some of the questions that are coming in. There are a number of questions. We usually get a fair number of questions in this webinar every year, so apologize if there are some of them we are not able to get to today. We will follow up with individuals with those questions that we are not able to address. So Kristine, maybe I can ask you this first question here. We have an initial one that came in that said, can you please help explain the difference between claim payment and remittance advice?
Sure. Looking at claim payment and remittance. Claim payment is the actual, I'm pulling up the definition so I can make sure I state this correctly. Claim payment is actually an electronic funds transfer from a health plan's bank to provider's bank, which includes the payment and date specific to the payment. Remittance advice is a transmission of explanation of benefits or remittance advice from a health plan to a provider. So the claim payment focuses on the payment at the exchange of monies, where the remittance advice talks more about the benefits and the explanation of the benefits associated with the service provided.
So another question coming in is related to, actually there's a couple of different questions. I'm going to combine them together here. Does the index currently ask about vision and pharmacy costs and trends? And if not, will those be included in the future? Kristine, do you want to take that one as well?
Sure. So currently vision plans and providers are not included in the index. And that's not to say that in the future they won't be, but currently they do not. On the pharmacy front, we've been working with NCPDP on a pharmacy service index for PBMs, which focuses on evaluating standards for the electronic exchange of healthcare information related to pharmacy services. And so we are currently working on that and hope to be able to share some findings if we receive enough volume in the next few months.
Another question, thank you for reporting on spend and cost avoided. Do you anticipate these metrics being included in future reports?
Yes, as long as we have the volume, we definitely will continue to report on this. We found that it's helpful to set the context and put our findings within the bigger healthcare industry. And the dollar amounts, as we know, healthcare spending has been discussed quite a bit lately in the news.
Another question is around attachments. Question is, given there is not an attachment standard, has there been any progress? Can you comment on any progress towards an attachment standard? I'll take that one. We have been hearing over the past couple of years that an attachment standard is forthcoming. But given the interest of the industry to work on an attachment standard to exchange medical documentation, both for prior authorization and for claims, and also considering for value-based payment as well, CAQH Core has been working with the industry to prioritize opportunities for attachments that the industry could work to standardize. And the results, that advisory group has concluded its work and made some recommendations. CAQH Core will be pulling together a work group to start developing recommendations for these prioritized areas early this year. So would ask individuals to look out for that announcement. And there's actually a core town hall that will be coming up shortly, where we'll be describing a bit more of those efforts. So stay tuned to learn a bit more about that. Another question that has come in is there a required prior authorization transaction? If there is, our vendor does not offer one. So I'll take that one as well. So there is a required prior authorization transaction. It is called the 278 transaction. So there is a required transaction. If a provider wishes to transmit a prior authorization through that standard, the health plan needs to facilitate that transaction and engage with the provider in that way. However, we do know that there is a lack of awareness, particularly on the provider side, around this required transaction. And from a vendor perspective, there has been a lack of offering those services. We do know that that is changing. There are a number of large vendors that are working to add that to their solutions. And often this has been a kind of chicken and egg somewhat issue where if the standard isn't being requested, the vendors don't develop it. So I think we are entering a space now where some vendors are looking into this, and we'll hopefully see more solutions become available to offer that service. Question coming in, Chrissy, I'm going to hand you this one. Can you explain in a bit more depth why the eligibility and benefit verification transaction is so much larger than the other transactions that are reported?
Sure. We have talked to plans and providers and have heard from both set of stakeholders that the increase in number and variation in the complexity of the health insurance benefits has resulted in a large increase in the volume. Providers may need to repeatedly call a plan to understand and identify specific requirements related to a patient encounter. And so for a patient encounter, you may have multiple phone calls or interactions between plans and providers as they continue to check on eligibility and benefit.
Sorry, I'm trying to read this here. The report mentions that there's 41 billion of 300 billion spent on administrative complexity for these transactions. What else is not included in the 41 billion? Can you give some examples?
Sure. It's a great question. So what is not included, some examples are credentialing, directories, quality metrics, systems costs such as EHR systems and administrative and clinical systems, regulatory and compliance, and I'm just trying at the end, and I'd already mentioned directories. So I think those are some of the complexities and other tasks that are not included.
Another question about prior authorization. We've heard about a lot of efforts in the press around prior authorization this year. Given all the effort, why do you think this transaction still remains so low? So I'll take that
Sure.
one. So as you've noticed in the report, the percent of the prior authorization transactions that are conducted electronically continues to remain fairly low, just increasing from 12% to 13% this year. To the question, there have been a number of efforts being conducted this year to work to address prior authorization. There have been a number of legislative efforts, both at the state and federal level. There have been efforts by various components of HHS within CMS and ONC to work on prior authorization. There have also been a number of private industry efforts among a variety of different provider associations, plan associations as well. And so there's definitely been a lot of focus on this issue. And as I mentioned before, there have also been a number of providers or a number of vendors that have been looking at the space to provide solutions as well. With all of the efforts, it does typically take a little bit of time for the industry to shift and to to adopt some of these solutions and come together. There's also, recently been passed some core operating rules as well that the industry can adopt. And so we anticipate over the next couple of years that we will see electronic adoption improve, particularly with, we assume, the continued industry focus to keep prior authorization at a priority for the industry. We have another question coming in here related to the dental industry. Kristine, do you want to address this one? Can you talk a little bit more about why it's been so hard for the dental industry to adopt this? What's different between dental and medical?
Yeah, something that we've dug into more so over the last couple of years, and have been really reaching out to some of the dental associations and organizations to get a better handle on this. So talking with some dental plans as well as dentists or dental providers, often they talk about the lack of vendor support. April had mentioned that in the call to action. I've heard many a dentist say, I would love to be able to, do this transaction electronically. There's just nothing, there's no systems, there's nothing available for me to do it with. So I think the lack of vendor support is definitely something that we hear repeatedly and continue to hear it repeatedly. In some cases, the dentists they have small offices and they don't often have the resources for electronic solutions or don't have the technical support or knowledge. So again, I've heard many dentists say, you know what, it's much easier for me to call or fax to get information or exchange information. And then one of the other big areas that's discussed or has been discussed with us for plans as well as dental providers is that some of the standards in the operating rules may not take into account the unique dental requirements. So it's difficult, for example, a dental provider to complete a form or fill out paperwork related to a transaction because either the fields are not related to dentists or the terminology is incorrect. So in all those instances, I think that is why the dental industry, lags, in addition to probably some other ones, but those are the big three that we've continued to hear.
Another question on attachments. Question is, we are piloting attachments, but are having some issues with how to manage all the other garbage items that are submitted. So the volume of information being submitted with attachments. Do you have any advice on how this could be handled with the workflow as this being discussed? So that's a great question. Actually, in a lot of the environmental scans that CORE has done around the attachment workflow, there's been a lot of discussion around solicited versus unsolicited attachments. And in particular, with on unsolicited attachments, which this appears to be a question about that, with just the volume of information that is submitted either with a claim or with a prior authorization request of medical documentation that was not requested, and there can be a large volume of information that can come in with those unsolicited attachments. That's been discussed quite a bit within the industry, and in particular thinking about what kind of operating rules can be put together to help with some of that attachment workflow. And one of the examples that I would share, kind of how in particular operating rules can help, is related to prior authorization. There's a rule set that CORE passed in May of 2019 that where the health plan is required to send certain codes, LOINC codes, PWK codes, to tell the provider what documentation is needed for the request, what specifically is needed, so that the provider is aware of what specific information may be outstanding or what should be submitted, as opposed to the provider just sending all the medical documentation that they have. So rules like that are things that we've worked on for prior authorization, and rules related to that are things also that likely would be under discussion during the attachments work group that is looking to start this year for CORE. Right. There's a question here, Kristine. I'll ask you this one. Does the data provided specifically highlight mental health providers, or are they included in the pool of medical providers?
But yeah, great question. They are included in with medical providers. So we have mental health. We've also had some occupational therapists, physical therapists. So during the data collection, our sample does include many different types of medical providers.
Another question coming in around prior authorization. Is there a list of states that you're aware of that require manual processes for prior authorization? We are tracking what different states are doing related to prior authorization. I don't have the list in front of me right now, but we can follow up with that on the states that have some manual requirements. Typically, the states that have some manual processing requirements for prior authorization, they're related to the notification period. So if a plan is going to deny a prior authorization, a letter needs to be sent to the provider and oftentimes the patient as well. Sometimes there's also a requirement for a peer-to-peer consultative phone call that would also be included kind of as part of a manual back and forth between a provider and a clinical reviewer on the plan side. So those are just some examples of things that are more common within the states. Another question, is the index always reported at the same time every year? When will the 2020 collection begin, and how can we participate in that?
Yes, so in terms, I'll respond to the first question. We anticipate and hope that the annual report will always come out in January and will report on the previous year's data collection effort. So the 2020 report is anticipated to come out in January 2021. In terms of when the data collection effort will begin, we're hoping to begin in late spring, early summer. We have found that if we start in spring, we tend to get more responses, given the summer months often are difficult and challenging due to vacations and people taking time off. And then finally, we are always happy to have more plans, providers, vendors, etc. participate. So if you have interest in doing so, you can reach out to myself at the explorations@caqh.org email. You'll also find a form that you can complete on the Explorations webpage at caqh.org. And if all else fails, you can reach out to anyone within the CAQH organization that you may have a relationship with, and they will direct you to myself.
I know we continue to have a lot of questions here. Again, apologize that we're not able to get through all of them on this call. We will follow up on the remaining questions. And very much thank you for joining the call today. I'll turn it back over to Maggie.
Yeah, thank you so much to April and Kristine as well for showing the findings today. And thank you all so much for joining us. As a reminder, early next week, you will receive an email with a link to the recorded webinar that you may share with your colleagues. You may also visit the CAQH website at www.caqh.org for more information, or email us at explorations@caqh.org. I hope you all have a great day. Thanks.